All righty. Let's jump right on in. I know you all are like, neuro, and you probably just want to walk out. No, I'm just kidding, right? We all love neuro. Y'all, if I'm too loud, I will find a way to turn this down because this is a powerful mic. And I have a powerful voice. We should all be careful. All right. So these 2 hours coming up, we're gonna revisit neurolocalization, really focusing even less on the anatomy than we did first year and highlight the clinical components, the true takeaways of, okay, when I see an animal that has a neurological deficit, what does that mean? How do I relate that to a problem in the nervous system? So kind of going back, pulling on some of that stuff that we talked about a mere 2 years ago, right? 2.5 now, I guess. Something I'm sure that you guys remember every single little piece of detail that we ever gave you, right? Super easy. You're like, no, what? There's a brain involved? No. So again, we're going to revisit all of this. We're going to start with the brain. And I'm doing it a little differently on this one because I want to go through each location where we can have an issue and talk about the different signs that you can see rather than going from the signs and saying, here's all the places where there can be an issue. So it's a little bit of a flip of a mindset than what you'll routinely see, with the hope that this allows us to say, okay, if I have a brain problem, here's my list of factors. If I have a cervical problem, here's my list of possible signs. And so that's kind of how we want to do it. Y'all, this comic here is one of my favorite in neurology because it's so true, right? Like you can diagnose, and I can get down to the neuron of where the problem is. Does that mean I can do anything? No. And I often joke sometimes, depending on what it is, the only difference between me and a general practitioner is I charge $3,000 to put them on steroids. Now, saying that jokingly, it's all right. It's funny. It's realistic, right? But what are they paying for? The knowledge, right? The comfort of knowing what it is and knowing what we're fighting and better define expectations because we know the problem. And so that's what they're buying. They're not necessarily buying a treatment or a solution. So just, context, right? Context is important. So when we talk about brain neurolocalization, we're going to break it up into cerebrum, brainstem, and then cerebellum and vestibular, right? There, of course, are multiple different functions of regions we can talk about. I don't think that you have to get it down to the level of the midbrain, to necessarily the level of the medulla. I think if you say, hey, you know what? This is a cortex lesion. This is a brainstem lesion, and this is a cerebellar lesion. Honestly, in the general practice setting, that'll get you there, right? Because those are the three big regions where we're going to have a lot of variability in our localizations. Remember that vestibular disease is a type of brainstem disease. All right, central vestibular, specifically central vestibular disease is a type of brainstem disease, but not all brainstem disease is vestibular, right? Remember that paradoxical vestibular, often 9 times out of 10 is going to be cerebellar in origin. And then obviously peripheral is neither, right? It's going to be our peripheral ear system. Now, this is something I want you to be aware of. You guys have probably heard this or at least heard some sort of modification of it. Disease is a spectrum, right? When I have a dog come in with a disc herniation, or a dog that comes in with a brain tumor, that dog can come in and present in one of a multitude of different ways. Let's take that back dog, for example. A back dog can walk into your hospital and say, ow, it hurts. And that'd be the only problem with a huge disc herniation, all right? Now, that dog comes back a day later. Doc, I don't know what happened to my feet. I don't know where they went. Has lost proprioception now. A little bit later, oh, I'm feeling a little weak in the knees, all right? And getting a little more difficult to walk. Maybe still painful, still has proprioceptive deficits. Moves down now to where they're paralyzed, completely paralyzed. Maybe we're now seeing increases or changes in tone and reflexes. And then all of a sudden, they can't move their legs and they can't feel their legs. And they are at the worst version of the spectrum, right? And so that dog with a disc herniation can present anywhere along here on this spectrum. And the clinical signs may vary based on the severity of the amount of neurological tissue that is involved, right? Over here at pain, we have just a little bit of the meninges or the nerve roots getting picked. All the way down there, those small, lightly myelinated, right in the middle of the cord fibers, the spinothalamic tract, where we carry deep pain from the feet to the brain, are now involved and compressed. So you can see the degree that we can have. And so for each and every location that we're going to talk about, know that we may see just one of these clinical signs. We may see them all. We may see a different variety in the spectrum. So just realize when we say decreased to absent reflexes, we truly mean it could be decreased, could be absent. When we say normal to increased, you would be surprised how severely the cord has to be damaged before you really see hyperreflexive reflexes, all right? The dachshunds especially, like they only need 20 to 30% of their upper motor neurons. Remember those neurons that live in the brain and the brain stem? They only need 20 to 30% of that signal to get down there. Once we go below that 20 to 30% threshold, that's when we see clinical signs. Y'all, having 20 to 30% of your cord or your functional axons left, that gives a lot of room for error, right? Like you can have a massive lesion and not have dramatic clinical signs. So again, just want you to be very aware that this is not an all or everything. Dramatic enough for you? Forebrain. Come on, y'all. Remember who you're dealing with. All right. Forebrain. So when I say forebrain, what does that mean? I'm talking cerebrum, i.e. cortex, and the diencephalon. Now, this is where things get weird because depending on how the anatomy group taught you or how even Dr. McCarty or Dr. Mansour or I came from it, people look at the diencephalon differently. Some people say the diencephalon is the top of the brainstem. Some people say it is a continuation and an extension of the cortex. And I do think that it is a bridge. I think anatomically, it fits and flows well with the brainstem. Functionally, because we can get seizures that occur at the level of the diencephalon, it functionally is brainstem. So yes, anatomically, it pops easiest and is merged easiest with the brainstem. Functionally, though, it has that ability to create seizure because it lives in this forebrain localization. Here's the beauty of seizures. Once you confirm that this is a seizure, and we'll talk in a week or so about how do we confirm that this is a seizure and not something else. Once you know that it's a seizure, you're done localized. Seizures only happen in the forebrain, right? There is no other option. Now, we can have primary tissues of the forebrain, such as a large brain tumor, that starts pushing on the brainstem. And when you start pushing on the brainstem, now you're going to get some other clinical signs. But just remember that seizures equals forebrain. Natalie loves that. Seizures equals forebrain. So what are some of these other signs of forebrain? And I'll tell you what, the vast majority of the time, I only see seizures present with these fairly large tumors. So don't, of all the ones that can be all or nothing, this one can normally just be seizures with a normal dog. Other things we're going to see is abnormal mentation or behavior change. So these animals maybe get more annoyed, more aggressive. One of the largest cellular tumor masses that I ever saw was a dog who rode around and spent his life with his dad, who was a truck driver. And all of a sudden, he really got irritable. Dad felt like he was annoying the dog more frequently. And sure enough, he had a large tumor that was pushing up on the base of the brain and pushing into the limbic system and really affecting how he viewed the world. You can get confusion, disorientation. You'll almost hear me use the word distant sometimes. It's as if they're living in the world, but not mentally. They're just kind of like, you know, no, we have fun. You know, all right, he's not there mentally, he's checked out. Loss of house training is a really big one because that is probably one of the higher level learned skills of our species. All right, now, of course, if they're hunting dogs, working dogs, sporting dogs, things like that, obviously you're gonna have a different degree. But for the vast majority of dogs that we're gonna see, going to the bathroom is as difficult as life. So loss of those habits or inappropriate changes, head pressing, compulsive pacing. We're not sure if head pressing is kind of a outward manifestation of like a headache in dogs. That's what we think. But the other theory out there is that it, like compulsive pacing, is associated with like OCD type forebraining things where you have to repeat it, kind of these compulsion type things. And we'll see these compulsion type things with some of our cognitive dysfunction syndromes. And when we see that, you'll just see dogs that pace. And then I get really tired and I take a nap. And then I pace, and then I pace. And we know that that is going to be stimulated by high degrees of the forebrain, specifically the really rostral frontal cortex. And then we have this hemian attention. Remember that the left brain takes in all the information of the right role, right? And so when you have a large tumor sitting here, you can develop what's called hemian attention. And what that means is everything's working, but you can't mentally process what's happening out here. Y'all remember that food bowl? And you're all like, yeah, that food bowl where it made me cry? Yeah, that one. And the food is eaten halfway down. That's that hemian attention syndrome. I can respond to the world, but I don't interpret it. I don't understand that food is food. And we see that contralaterally as this brain is unable to process this world. Now, gait. Gait is one of those things that, unless you have a massive acute lesion or something that's pushing on the brainstem, these animals are walking into your clinic. So this is the large brain tumor that's coming in and saying, hey, doc, how's it going? Oh, hi, again, right? And so they're walking around with good strength. They may have proprioceptive deficits. They may be circular, but you do not see the weakness of the legs. They're able to support themselves. They're able to move. They may be ataxic to a degree because of the proprioceptive loss, but they do not show weakness. They have normal strength. And remember that strength is different than ataxia. Weakness and ataxia are two different things. Ataxia is a loss of coordination. Strength and weakness are associated with motor function and tone. When you circle in the forebrain is one of two locations where animals circle. Forebrain, vestibular. Forebrain, vestibular. Those are the only two locations. If you don't see vestibular signs, guess what? It's in the forebrain. You always circle towards the lesion. You always circle towards your lesion. And some of that has to play into how the world's processing, and they think they're walking straight, but because of the inattention, they're actually walking in circles. But because they can't interpret half the world, they don't know to balance themselves out. And so it's a mental incapacity to walk forward. There is this theory that forebrains are more wide, vestibular is more tight. I would say that that's about half of the neurologists believe that, and the other half think it's complete pooey. I'm in the pooey camp. All right. I've not seen enough cases that I feel that is always the case. So I think circling, you're like, okay, maybe forebrain, maybe vestibular. I would use other signs, looking for nystagmus, looking for that vestibular ataxia, head tilts, things like that, to put me into the vestibular camp. Realistically, does it matter if you're going to image this dog? Does it matter? No, because you can look at the whole brain anyways, right? It really matters when you're developing your differential list. And if this is one versus the other, chances are you might start getting more information as the disease progresses. Yes. Yeah. Speed. Yeah, so he's asking, how do you differentiate quicker turns, spins versus larger? I do think the vestibular tends to be a little bit on the quicker side versus when you do see that kind of like walking and hugging the wall, kind of like circling. I think those dramatic spaces can help you with it, but in terms of like this dog that just goes in circles here in the middle. To my knowledge, that'd be a really cool paper to go back and do this. I don't think anyone measures the speed at which they circle. So, you know, if you're looking for a study, let me know. We're gonna set up. But that would be cool to see, right? Like this, the how quick you circle doesn't. I'm not aware of a paper. We know that the nystagmus does, because the faster the rapid eye movements, the more likely it is peripheral. But I don't know that there's anyone who's looked at that as like a degree of circling and really quantifying the circling outside of these very wide or very tight rapid circles. That's a great question. I don't know the answer, but it's a great question. All right, proprioceptive placing. Remember, because this left part of my brain interprets the right world, the somatosensory, the sensation, the feeling that I have in my paw is going to travel up my right arm, go up to my dorsal root ganglia, into my spinal cord, and then up to my brain on the opposite side. So you will get proprioceptive deficit. So if I have a left-sided brain tumor, and it hits my somatosensory cortex, which in dogs is going to be kind of around the middle, you're going to get proprioceptive deficits on the contralateral side. The diencephalon lesions, theoretically, depending on where it happens in relation to the right nucleus, because what happens is these pathways come up, and as they're crossing, they cross through the thalamus into the cortex. So in theory, you can have a diencephalon lesion that tricks you. They're pretty uncommon and rare, to be honest with you. So I wouldn't worry about it too much. I would focus on the contralateral. Those thalamic lesions, they confuse even great neurologists because they're just haphazard. It's like a grab bag of clinical signs. Whatever we want it to be, it's like, yeah, sure. So it's when it doesn't make sense. We're like, maybe you're in the thalamus, the diencephalon. Remember, for proprioceptive placing, you must support these patients. And I'm not talking emotionally, I'm talking physically. All right. You have to get up under them and make sure that you provide hip support or chest support, because if those animals start to fall as you are testing proprioceptive placing, you're now testing vestibular dysfunction. You are not testing proprioceptive dysfunction. And then remember that orthodisease, systemic weakness can lead to false positives. Bilateral cruciates and saddle thrombus dogs and hypovolemic dogs that are bleeding in their abdomen are the top 3 reasons that dogs have proprioceptive deficits, is because they're too weak to physically move those legs. None of those are neurologic in origin. So don't get tricked. Always do a great neuro exam and general. So let's talk about cranial nerves that are affected by purely cortex lesions. Because remember, some cranial nerves are going to be involved in some of these learned responses. Number 1 is Menis response. Menis response, remember, is going to be cranial nerve 2 to see, contralateral brain to interpret, and 7 to believe. You want to take it to a higher level, you can say it's also the ipsilateral cerebellum to oversee the process. With that being said, it should be 2 to see, 7 to believe. When you have a Menis deficit, it means you cannot interpret danger coming towards your eye. Remember that the Menis response is learned around 12 to 16 weeks of age in small animals, or closer to 7 weeks in prey species. And this is the idea that the world is out to hurt you. It takes you about 12 weeks if you're a dog to learn that. All right. Took me about a day to figure it out around here. I'll cry later. That being said, remember that this is a learned response. It is not a reflex there at birth. So it is a learned response. You have to learn that the world wants to hurt you. And so once the cortex can do that, it is now the cortex's job to take that information and say, hey, something's coming at my face, probably gonna hurt my eye, I'm gonna close it. And that's where the Menis response comes from. When we have the Menis response and it is a cortex lesion, a lesion in the brain, y'all, that is normal PLRs. Remember that division, whole vision, tough one, right? When you get after the optic chiasm, PLR pathways stay in the brainstem, cortex lesions go up, right? And so we separate Menis and PLRs. So Menis goes up to the cortex, PLRs will always be normal. And this can help give you that cortical blindness where your eyes are functioning, but your brain is functionally blind. So this is just kind of another thing. If you really want to deep dive into Menace pathway, literally it is like a 20-point pathway. So let's just say 2 and 7 and call it good, shall we? Because we ain't no time to learn 20 points of pathways. If you want to become a neurologist, as a resident, I'll help make you cry and we'll make you learn about it. All right. That being said, I think if you just remember cranial nerve 2 to see, brain to think, 7 to blink, you'll be good to go on Menace. And just remember it's contralateral to visual field. Right visual field, left brain. Left visual field, right brain. We can subclassify it because we do have a little bit of each part of our brain. This is a little bit of our eye. Because animals can't talk to us, it's much harder to appreciate that. So if we just think right visual field, left visual field, that'll be great for a general practice level. Again, if you want to get more higher up, we can absolutely get you there. PLR, kind of sticking with that, cranial nerve 2 to see, cranial nerve 3, specifically the parasympathetic branch of cranial nerve 3, which has its own neuron. Cranial nerve 3 is going to constrict that pupil in direct versus consensual. Remember that different species do this at different rates. You have to have a healthy iris. So these old 18-year-old chihuahuas who have seen some things, and their irises are like just like wispy little pieces of string. Yeah, they would have PLR, right? They have no iris in which to focus. And so those animals have to have a healthy iris. You also have to be able to get the light into the back of it. And so remember that vision is one thing, light is another. If you go back to those lectures I gave you first year, and I'm happy to resend, there is a step-by-step PowerPoint that you can click through on the PLR pathway. The only 2 pathways that I think as a clinician, you really have to have a decent understanding of is vision and PLR, because it helps you tell where the problem is. I don't think it benefits you to remember, oh, the spinothalamic tract is the one that carries pain, or, cerebrospinal is the one that makes you walk, right? Those are fun facts. Do they change the game at the end of the day for you as a clinician? Probably not. These ones will, because this is the difference of giving something optic neuritis versus a pituitary lesion, versus retinal disease and things like that. So this can really help you in the eye region. So just kind of be willing to jump into those. And again, happy to resend that PowerPoint where you can click through the PLR if that will help. Speaking of pituitary lesions, now I know what you're thinking, Dr. Gibson. What kind of neurologist are you? The pituitary is not part of the forebrain. It's a little thing. You are correct. However, you get a big old tumor like that, it's going to push up in your forebrain, right? And so you have that ability now to start losing Menace, start losing PLR. And I will tell you that cats are more sensitive to pituitary lesions than dogs are. That dog that was with the trucker, that was the largest tumor I've ever seen. And that dog, other than being irritable, had no other deficits. That tumor was taking up half his skull. And then the only deficit he had was he was a little irritable. Y'all, mind blowing. Cats, something pushes slightly up on their pituitary and they're like, oh, I'm like bothered. You're like, okay, cat, cool it down, bro. And so just know that cats and the optic chiasm tend to be more sensitive with pituitary lesions than dogs. I don't typically see that optic chiasmal blindness that we see in cats with pituitary lesions in dogs, and we think that's because the dog chiasm sits more rostral, whereas the cat's chiasm sits close to the pituitary. All right, so this is a great example of a dog who has new onset seizures, specifically cluster seizures. What I want to show here, do you see the strength of those limbs? Do you think that this dog looks like he has a brain tumor? No, but he does. And so again, this just goes to show you that you can have a brain tumor and walk very strongly with good strength. Now we start looking at some PLRs. We're going to do Menace, good PLRs. So I know that cranial nerve 7 is functioning, right? 5 and 7 must be good to go. And I tested 5 and 7 so that when I test Menace, I know exactly what's happening. No Menace there, huh? He's like, I ain't scared of you. And then we'll go over to this side. It's very hard to film, do menace, and do it all at the same time. Now, he's doing a little bit of blinking there, right? Yeah, and so that one was a little bit, but yeah, he didn't have much blink. He had a little bit here, but it was still decreased. And he actually had his tumor on this side and inflammation over here on the right. So he was globally affected, all right? And then this is proprioception. This video you actually saw 2 years ago. Again, that's going to be proprioception. See how she's holding up that chest? That way she doesn't accidentally test the vestibular system. So that proprioception. You're going to see people who take that paw and flip it, and they're going to fling it as if it's a dang boomerang. Paw placing test, not paw flipping test. Paw placing. What you don't want to do is just the dog's like, yeah, I felt that way up here because you swung my arm out of socket. Go slow. Again, she's going to support it. Obviously, she watched for the berries there. Be cautious. Don't lift a dog up by those. That's more of a personal antidote. They don't like it. I was young. I was dumb. All right. So in this animal, we had new onset seizures, absent menace bilaterally, and right-sided proprioceptive deficits. So knowing that both of our brains were affected, which side was more affected? The right brain or the left brain? Left brain, right? Because the proprioceptive deficits. Right-sided proprioceptive deficits. So left brain, sorry. Left brain. I was watching the video flipped in my head. My bad. But yeah, this is left brain is worse than right brain. All right, left brain versus diffuse, right? And we know that it's diffuse because we had some edema, and then his tumor was on the left-hand side. And there it is. Now, we did actually a CT, because this had a lot of contextual factors. You talk about spectrum of care and contextual factors. Let's just say this man was up banging on our doors at 2 a.m. after a dog had a seizure. All right, so this is a brain tumor, all right? And we'll talk a little bit in the brain tumors about what it looks like. But when you see this kind of tumor of a dog that's 8 and it's inside of the brain itself, so it's in the parenchyma, that's going to be in our glioma classifications, right? So glioma, basically think brain tissue, meningioma, dural tissue, right? Those are going to be the two big ones. So this one was inside of the skull. All right, so what did we do for this guy? We treated the seizures. This particular forebrain example is a really wild case. I'm going to more talk through this one because this one was actually so wild we ended up publishing it. Here you can see that palpebral is functional. And then palpebral is functional. Again, we're testing that because we want to make sure that 7 works. So that if we get menace deficits, we know now that it is menace and not just cranial nerve 7. That dog ain't blinking. All right. Come over here, a little bit of blink. Still a little inconsistent. You can see she was actually testing subfields. Now we're testing oculocephalic reflex, which was normal in this dog. She's testing 7 and 7, making sure that 7 fits all the way around, make sure we're not missing a facial palsy or paresis or plegia. Now we're doing a little nasal sensation. Boop. And now she's going to go in for the PLRs. Very hard to do on a tall table. What do y'all think? Nah. Nothing changed. Again, very hard to do this in video, and I clearly was not helping her. All right, still not great. These PLRs are not great. So there's she doing her menace again. Again, this time she's letting the dog cheat. You see a little bit of menace there on the right side. So if our PLRs are diminished and our Minus is diminished, possibly vision, right? Where along that visual tract do we know that this lesion has to be? Optic chiasm or forward, right? And so that is also the optical nerve that we're in. So optical came in and said, ooh, that optic nerve is black. Melanoma black. Yeah, so this was a melanoma that was growing in the optic nerve down to the optic chiasm. And so the reason we saw this kind of like partial PLR change in the other eye is that it actually was starting to grow onward to the other side on this. And this actually, we ended up writing up this case because it was so bloody cool. So there's all of those. Again, who would have thought that, but there it is. That is not what the optic nerve is supposed to look like. It should be nice and white. That one has darkness. Dark optic nerves are not happy optic nerves. So this is that dog's tumor. So see all this white? This is a T1 weighted image on MRI. Nothing should be bright on here. But melanoma is one of the two cancers that shows up bright without contrast. So this dog did not get contrast. And it's showing up bright. All right. So as soon as we saw that, we were like, oof, this thing is diagnosed. Hello, Javen, here we come. Brainstem. Yeah, go for it. Yeah. Yeah. Did I not include that one in your notes? Oh, I'm a dick. I said I'm saying that one for publication. What a jerk. Okay, no, I saw a couple other people. You weren't the only one. I don't know why I deleted it out there. I'll go fast. All right. So in diencephalon, again, anatomically, a part of the brainstem, functionally, probably more like cerebrum. Midbrain, pons, medulla. When it comes to brains, mentation plays a huge role. Because remember, yes, the cortex is where we think we be, but the cortex has to be woken up. It has to be aroused. And again, remember, not that hey baby, how do you do it aroused? That I'm alive, I'm aware, I love the world, right? We have to turn on the cortex, and that is the brainstem job through the reticular activating system, right? Specifically the ascending reticular activating system. And gait. Remember, we talked about a couple years ago that quadrupeds are extrapyramidal species. We are pyramidal species. What does that mean? We use more cortex when we create motor movement. This species, dogs, cats, anything quadrupeds, uses more brainstem. And that is the brainstem's function is where gait is generated. That is why a stroke in a human will cause muscle weakness. Because the upper motor neurons for us are primarily that corticospinal tract. For dogs, cats, and those other quadruped species, their primary is the rubrospinal. That comes from the brainstem. That's why dogs and cats can have these huge tumors or these large vascular events and still walk around. But we would not be able to do that because of the way that we are programmed and the way we are set up. And so once we get to the brainstem, that's where we'll start to see both proprioceptive and vestibular ataxia, because both of those systems either start or run through there. All right, the vestibular system literally lives there. Proprioception runs through there. And then increase to normal tone and reflexes, because the brainstem is either going to be the home of our upper motor neuron pathways, or it is going to be where those cortical upper motor neurons run through. So again, we're either damaging the home of the upper motor neurons, or we're damaging the path in which they go. When we damage upper motor neurons, we get signs of upper motor neuron dysfunction, which is that increased tone and those increased reflexes. And I will make sure I send her that link. I think a year ago, I made a video that was like, still confused by upper motor versus lower motor neuron. And it's a great like 20-30 minute video of like just busting through upper versus lower motor neurons. So I'll make sure that you guys have access to that as well. I keep thinking you had your hand up because of the cardboard behind you. I'm like, yeah, what you got? I was like, no. So use your other hand, use your right hand if you have a question. Just keep seeing the wrapping paper. All right. So when it comes to brainstem, we're also going to be looking at posturing. Decerebrate rigidity is the clinical rigidity, the clinical presentation, if I were to cut the cortex off of your brain. Remember, the body wants to be naturally in tone because lower motor neurons, they're good at two things: facilitating reflexes and creating tone. And so the reflexes, or sorry, the lower motor neurons, the workers of the body, are going to do just that. Tone. And it is the upper motor neurons' job to say, hey, hey, we have a really small warehouse. Tone it down. Joking right home. Tone it down. So the brain is all about toning down the body and letting us kind of go a little bit limber, a little bit looser, right? Well, if I cut the cortex off and cut all the messaging system from the cortex off to the spine goes into default mode. Default mode for the body, when the brain is not involved, is tone. And that's why you get decerebrate rigidity. Decerebrate rigidity is extension of all the limbs, opisthotonus, which means the head is thrown backwards. But because it's involving the brainstem, remember, that's where I keep my ascending reticular activating system. That arousal, that on-off switch for turning on and off the cortex so that I can use it. Well, if I have a brainstem lesion that is severe enough to cut all of the upper motor neurons off from all the lower motor neurons, it's also going to affect my consciousness. And so the classic presentation of decerebrate posturing is extension of all limbs and a lack of mentation, a lack of consciousness. Y'all, this or decerebelling will be on your napkin, period. Because these are classic postures and classic presentations. Here's the dirty little secret about neuro. We don't know how to treat nothing. So it's real hard for them to ask you about the gold standard treatment in neurology. All right. But what can they ask you about? Postures and neurolocalization. All right. So that is why we're going to hit neurolocalization so hard. All right. Within the brainstem houses all of our cranial nerves. So have you guys talked about cranial nerves since Dr. Mansour mentioned them a couple years ago? Okay, good. Well, glad. I got a couple no's in there, so hopefully we're all taking the same classes. But let's do a quick refresher. Right, cranial nerve 3, ocular motor. Ocular motor does two things. It controls the orbit of like the eye in the orbit, left, right, up, down. It also controls the iris of the eye, right? So one is through a somatic or motor, the other is through parasympathetic. We're going to have cranial nerve 4. Cranial nerve 4 only can be seen in cats visually. All right. Other species we either have to get creative and look at. I guess horses can be seen. Okay. But dogs, cranial nerve 4 is very, very hard to see. Do you guys remember how you could tell if you have a cranial nerve 4 lesion? What? You could, but not cranial nerve 4 by itself. Ooh, say what? Oh, okay. I mean, you were saying the answer. Yeah, of what though? If it's a circle on the outside, where else could I look? If I can't see it on the outside, look on the inside, right? Dr. Bowden probably went over the funding exam with y'all, showed you all those vessels. If those vessels are rotated, you got a cranial nerve 4 lesion. That's right. Y'all, the windows are the eyes are the window to the brain. That's how you see the nervous system. How exciting is that? Yep. So you're doing a funding exam and you're looking to see if you have rotation of those vessels. Obviously cats, because they have the slit, much easier. Cranial nerve 8 and 3, 4, and 6, which are going to be all of those extraocular muscles. This is going to be the extraocular reflex, aka Doll's eye. So this is normally your what we call physiologic nystagmus. So that ability of your eyes to move when your head moves. and you should have a normal physiologic nystagmus. This is how they evaluate for like brainstem dysfunction or what we call brain death in humans. All right, we use it to some degree as well, but what it is we're looking to test either cranial nerve 8 or 3, 4, and 6 and see if the eyes move when we move the head. If the eyes no longer move when you move the head, it suggests that you might have a severe enough lesion that has damaged the brainstem. And remember, where is consciousness control? In the brainstem. And so we often get it confused that, oh, I have really nasty brain injury of my head, and so now I'm in a coma. Well, to be honest with you, a lot of coma patients have brainstem dysfunction. And it's much easier to get put into a coma with brainstem dysfunction because you need a much smaller real estate to be affected, whereas you would need the entire cortex to be affected to put you in a true coma state. Realistically though, most comas are induced, not natural. So most of the time it's us taking these patients and saying, bedtime, all right? Let your brain calm down. This is my one case of trochlear rotation in a cat. One case, that's all I've ever seen. It was a good day at work though, got excited. You can see we went and got the professional photographer. Those people around the lobby like, where's my cat? Bro, your cat ain't leaving today, sorry. Too many pictures need to be taken. All right, did I put that one in there? I'll give that one up for free, clearly, all right. So, in the cranial nerve, the midbrain is cranial nerves 3 and 4. Remember, 2 is going to be our chiasm, 1 is all the way up there with olfaction, kind of its own thing. So we're working our way backwards. Cranial nerve 5 is the only one that lives in the pons. Now, it gets a little bit more complicated than that, but in general, think of 5, think of pons. So if I have a pontine lesion, now I'm going to have cranial nerve 5 damage. And remember, there's a couple different functions. There's the sensory function of 5 that allows me to feel my face. Anyone remember the part of the face that 5 does not provide sensory function for it? Sorry, I couldn't hear you. Inside of the ear. Inside of the ear. Yep, so that inside of the ear is cranial nerve 7 to feel, 7 to move the ear. One of those weird oddities. 5 is everywhere else. And so you get that sensation over the face. When we did that nasal test, that nasal sensation test, you saw her close the eyes, stick a little something in the nose. That is 5 to feel. But then cortex to say, hey, something's in my nose. That's because of cranial nerve 5, that's why we can't use like caustic agents or like chemical smells or things like that to test for smell, because 5 actually gets activated much easier than the olfaction. And so 5 gets in the way of testing 1. There's also the motor function of 5. All of those trigeminal innervation of the muscles of mastication, temporalis, digastricus, masseter. It also has some roles in tear production in terms of like, it lets us know when we have dry eye and it helps create tears. Well, if I have trigeminal nerve dysfunction, you may not feel the dryness of your eye, so you may alter or have weird tear production. So how do we test cranial nerve 5? Visual exam, all right. Palpebral response, we're going to be looking and testing for if they blink when we touch their eye. 5 to feel, 7 to blink, and then that nasocortical sensation. Put something in their nose, cover their eyes so they don't see it coming, and see if they respond. I do not care about high or low response. I care about left versus right. Just left versus right. They can completely ignore it if it's equal. They can completely hate it as long as it's equal. But I don't want to see the left and right be dramatically different. That's what I'm looking for, not necessarily big versus small. Obviously, if you can shove it up there and they don't care, a problem, but it's got to be pretty dramatic. So palpebral reflex, just as a reminder, that is 5 to feel, 7 to blink. 6 also gets tested when you do palpebral. 6 also gets tested when you test minutes. So you have to be cautious, because if one of these, like cranial nerve 7 or 5, is broken, but the eye sees it coming, what can happen is the globe can retract. When the globe retracts, what do you think mechanically happens to the eyelids? They close, right? And so all of a sudden you're like, it's normal. And you're wrong, right? 6 just retracted. Now, this is, I think, more dramatic with menace response than it is with top people. But just be aware that when the body sees something coming at it, 6 is going to try to retract to get the eye out of the way to help close that eyelid quicker. So just be cautious of that. And again, the day you see it where you have like paresis or like facial paralysis, do menace and just watch that eye go. It's really wild. And then nasocortical sensation, 5 to feel, contralateral brain to interpret, and you must cover the eyes. Do not let these animals cheat. Cranial nerve 6, we talked about just briefly, but that is going to be the abducens nerve. It lives in the medulla. So now we're starting into our medulla oblongata. Medial strabismus, no retraction of the globe if you have 6 issues. And this is tested by visual exam, oculocephalic reflex, and corneal reflex. Now, we don't necessarily test corneal reflex day to day because it requires us to touch the eyeball. When I touch the eyeball, I run the risk of damaging the eyeball. All right. And I prefer animals to not have to go to Dr. Bowman and me being like, hey, I missed that. All right. So we actually save corneal reflex to help us evaluate for death. And so I'll use corneal reflex after euthanasia to see if they blink or respond to touching of their eye. And that's 5 to feel, 7 to blink, and 6 to retract. Facial nerve is going to be all about muscles and movement of the facial features. So these are separate from the jaw and the muscles of mastication. These are the ones that allow you to smile, to grin, to grimace, to fall in love. All of those things, right? Of all those facial expressions. When we lose this, we get a facial drooping. Now, you have to be very cautious because facial drooping in humans screams what? Stroke, right? And that's what a lot of people think when they think, oh my gosh, my dog has a stroke. No, it's more likely that they're dealing with a cranial nerve 7 dysfunction because really they would have to have a stroke to their brainstem to get that. Because the stroke up here, because they are extrapyramidal, we don't get the same type of cortexual control of our face, right? How many of you has a dog that, well, don't answer that because some of you may have judging dogs. But realistically, do dogs make the same degree of facial movements we do? No, right? They're in like, you know they're thinking it, but like, it doesn't show, right? So just be aware, they don't control their face, and that's why they're not as affected with a stroke to their face, because again, more extrapyramidal, not pyramidal control. So we'll be looking for that droopiness. We'll also be looking for a lack of retraction of the muzzle and inability to tap the face. Vestibular, y'all, that's its own lecture. We'll just do a vestibular day and revisit that because if vestibular is a toughie. All right. So we'll come back and talk cranial nerve 8 all by itself. We'll give it its own little day. And then glossopharyngeal and vagus, that's going to be all about gag, dysphagia, inability to swallow, laryngeal paralysis, potentially even megaesophagus. And so those are going to be some of the things that you look for. The other thing I'll add in there is called food packing. So if you open the jaw and you look in the back of the mouth and you look on the right side or the left side, kind of in that little crypt, it lives right back there where the jaw kind of comes together. If you see food or saliva packing in there, that's called food packing. And you might actually see that be a sign of dysfunction on that side. Again, this is the corneal reflex. Here's how to do the gag reflex, 9 and 10. 11, I hate cranial nerve 11. Clinically, it's very difficult to see because it's all about these muscles that are over the neck. Now, with really severe lesions, you absolutely can. But again, not something that we spend a lot of time talking about clinically. And then hypoglossal is all about tongue movement. All right. Remember that the tongue pretty much has muscles that are sticking up. If I damage the right side of my tongue and it shrivels, now this is going to fall over, right? The contraction of that muscle is going to pull my tongue over to the damaged side. Now I'm only able to lick on the damaged side because of the contraction. Thank you, phone. All right. And so this is how you can tell, like, okay, if I have a single cranial nerve dysfunction or brainstem dysfunction holistically, all right, just some ways to break those apart. And then this is a very complicated brain case. We'll actually save it for tomorrow. All right, and we'll stop here and we'll pick up cerebellum in 10 minutes. Yeah. No, because it's the body never programmed that to run through there, so you don't necessarily get it.
So can it look like seizures look like that?
Like looks like that posturing?
Yeah.
Yes, because you're losing the tone.
Yeah.
The control. So that's why you get that rigid extension. Oh, yeah. Yeah, and that's probably more like, I would wonder, like, if we have like hypoplasia, do we have other things like hydrocephalus? Are we having other fluid shifts or things like that that change the pressure? Because pressure changes can also. Test me. So test me, yeah. Oh. Oh, go for it. Hey, hey. How about yourself? Hi, how are you?
Good minute then.
Sweet. I did. What are you not doing? We used to actually have these recorded and I just wanted to leave it alone. So it's great having. All righty, let's jump back in. We'll finish up brain and move down to the spine. All right. So I think of all of them, brainstem tends to be the most difficult aspect. Once we get through today, I will also create, I've been working on a few worksheets that help with localization and really diving into it. So if you really are struggling, I'm happy to make those available to you guys. Because I think y'all had like my first one or two that I made. Now I have like 15. So I will make those available to you guys. That way, if you are struggling with localization, deep diving, where things connect, how things connect, that's really aimed at the early career vet. And okay, what do I need to know about these problems? And it comes from more of like a monoparesis, or hey, I got a dog that's paraparetic. What does that look like? How do I break that down and what am I looking at? So it's kind of a worksheet version of these lectures. So when we talk about the cerebellum, realistically, the cerebellum is kind of neurologically boring because it is fairly classic. Its mentation, cerebellum should never affect mentation, right? There's like exception of if you're damaging the flotilla nodular lobe, which has input to the vestibular system, and that's what causes a version of paradoxical vestibular disease. That is going to disorient the animal, but disorientation and being drowsy and dizzy is not being mentally incapacitated. So mentally, these animals should be alert and be able to respond. They will have normal strength, but they will become ataxic, and this is from purely cerebellar lesions. Again, the strength is not affected, but the way the coordination is. And so you get this hypermetria or this cerebellar ataxia. And it really is kind of this like overreaching type approach in all four legs. Now, the big differentiating factor is that when they go up, they slam it down. Why do I say that? Because really, really high cervical lesions, like C1, C5, or C1 to C2 region, can also create this almost slightly hypermetric, more floating type gait, because we have upper motor neuron tracts running through, right? Upper motor neuron tracts help to coordinate and facilitate some of that gait. Well, if you have too much tone in your thoracic limb, you get more of a floating gait than you do your normal walking gait. So there's a little difference between those two. The classic cerebellar is this like hypermetric slam down. It's not kind of like an equal type of phasing effect as you go out and come back in, if that makes sense. So just, I don't want people getting tricked up or stopped up on things like that. Proprioception can be normal, or it can be delayed or exaggerated. And it all comes down to which part of the cerebellum is damaged. But remember that the cerebellum controls unconscious proprioception. So it is the cerebellum's job to know what's going on with our body without telling us. So our cerebellum always knows. And the good news is that's what helps us have these smooth movements. All right. And because it can take what the brain wants to do and where the body's at and says, yep, let's put those two together and let's make it happen. But not all cerebellar lesions lead to proprioceptive deficits. Posture. Now, we talked about decerebrate. Now we're going to talk about decerebellum. What if I take a cerebellum and I pop it off the brain? All right. You did use the right hand in your defense. I just was ignoring you clearly. What's up? Okay, random answer. I don't. What's like when you're like when I close my eye? Is this okay? I'm not trying to be like, oh, she's crazy. I've never experienced that. Well, okay. So I don't think so. But I do think the proprioceptive system is involved. And so, do you have to close your eyes to get this experience? Because I can think of like, okay, I haven't had the one, I guess I'll stand there with my eyes closed more now. I got something to do tonight during play practice. I'll just stand in the backstage and be like, nope, doing science, leave me alone. I'll report back tomorrow. But my suspicion is that you're taking away the visual input and that it's more your vestibular system that's going to make that less than cerebellar. Yes, really. No, please, because I've never experienced it, so I don't know. Oh, snap. Y'all, so I'm just living my life not floating. Y'all teaching me stuff today. I like it. I'm really gonna do this tonight. How long does it take? Okay. Oh, so you can do it sitting? Okay, it's gotta be standing. You swear? I'll let you know. I'll test it tonight and then I'll let you know what I do. I love this. This is great. Together. So tight together like this, like you're at attention. Okay. We're doing science tonight. It's all right. I'm all like, I got a big block of time where I'm backstage. They're gonna think I'm weird, but I don't care. It's for science. Doing science. I'm gonna get a sign doing science. I suspect it's gonna be more vestibular based because now your vestibular system is like, wait a minute, I need some sort of input. And it's probably trying to create input at a mild degree so that it can correct and autocorrect because it's not getting any new stimulation, right? That's my suspicion, but yeah, I'll try it out and see if that's theory holds up. I'll do it in the far corner, no, I don't feel their wind. I've never been asked this, but I love it. I've never had this history. I'm excited to float tonight. I'm gonna be like Alpha, I'm gonna fly. I'm gonna fly. All right, so back to neuro. So cerebellar posturing, decerebellate is like if I pop off the cerebellum from the system. The biggest difference is the back legs. You actually end up flexing at the hip. You still have some extension to the limb, but you're flexing at the hip. You still have osteotonus, but the number one difference is consciousness. This animal should be able to look at you and talk with you while they're laying. All right. If you understand them, that's a different medical condition for you. But what I'm saying is they should be able to be in the moment with you, right? They should be aware. Does not affect mentation because it's the cerebellum. So it does not attack the reticular activating system. Both of these actually, but especially this one you have to differentiate from shift shearing. Shift shearing, to remember, is when I have a T3L3 lesion and that middle manager from the lumbar system that is sending inhibitory signals up to the thoracic limbs. And it's saying, hey, thoracic limbs, I'm also in charge of you. Stop making tone. And so it's going to help us release. It's doing the same thing as the brain, it's just like a middle manager. Well, when I damage that system, you also get increased tone. It's the one time that we have a signal where you can have a lesion behind a problem and the signs show up cranial, right? It's one of the few scenarios that we have. And so when you have this, you get these really stiff thoracic limbs. The dog is very aware, but the pelvic limbs are paralyzed. So what we have to do is we have to kind of turn the dog up once we're pretty comfortable that it's not like a fracture or something like that, and then get them to walk, test their proprioception, things like that. Because cerebellar decerebellate will not really have great motor, will have proprioceptive deficits, but shift Sherrington will only have increased tone. Everything else will be normal, only increased tone. And we'll talk a little bit about that when we get to T3L3. Yes, ma'am. Yes, but you're also going to see like some cranial nerve dysfunctions with that. You'll get that sardonic gland, the ears will be pinned back. And so you definitely, it's one of the, I would definitely consider it a differential. But with the tonus that you have with tetanus, you'll tend to also be able to respond to the sound and things like that. So there'll be a couple subtle differences with that as well. And I would expect things like menace, which can be affecting, that's actually what we're talking about now. Menace is affecting the cerebellum, not so much with that. So there's a couple, they're subtle, but actually I think that's a great question that you have, like, hey, both of these create the Tony type thing. It would really, the other thing I'll tell you is those back legs, tetanus back legs tend to kick out. These tend to flex under. They're tight, but they flex. So that's another way to differentiate. Great question. Remember that the menace pathway, one of the 20 stops is going to be in the cerebellum. So when you have cerebellar damage, you can get menace response ipsilateral to the lesion. So if I have a right-sided cerebellar lesion, I expect my right menace to be affected. You may see an eschoria, widened topical fissure, third eyelid elevations. We're not quite sure all of these. Intention tremors are by far one of the classic clinical signs. You have food and you're trying to make an intended movement, and all of a sudden you have a dog getting all walk, right? It's like, no, I want this. And it just looks weird. He's trying to make a movement, but he can't coordinate these movements. But he really just wants that snacky snack, right? And so as we're going through, it is always voluntary movement. So a cerebellar dog should not be laying there trembling. If a dog is laying there trembling, that is not an intention tremor. Intention tremors require a desired voluntary movement, such as going to get food or water. So it has to be an intended movement. That's what we mean by intention tremors. Titubation is a forward and back or side to side swaying motion. It's a little bit more dramatic than what we were talking about a little bit earlier. And when you see it, it's kind of more of just this like body sweat. Yeah, kind of like, yeah, like it's just out and then like, oh yeah, I like these. All right, and it can be forward, back, or side to side, all right? And it's always cool when we see it, we're like, titubation, it's my favorite word in veterinary neurology. All right, and then vestibular dysfunction, we know that this has a component in the vestibular system, and we will talk about that in depth with the vestibular. Drew on that. That would have a little extra flair on it. All right. Any questions about brain? You guys feel comfortable that you can differentiate between those three subsets pretty easily? Or you like after, yeah, give me some time. All right. So again, yes, we can get deeper into the woods there. I promise you we can. But I think if you can remember those special circumstances of like, when is menace affected and how do I tell the difference? Neurological localization of the brain is mostly a math problem. This clinical sign plus this abnormal test minus this positive test equals this function has to be affected. And so when you're starting to work through, and I put this on the worksheet that we're going to do for tomorrow, there's an example. Start going through and say, okay, menace is absent. Well, that's 2 and 7 in cortex. Then say palpebral is also absent. Well, you know what controls both palpebral and menace? 7. And I wonder if I go and pinch the muzzle, yep, that's not working. And I got a little facial droop. By golly, this must be 7. So you're going to take all of these tests and you're going to say which ones are affected. And then from those affected tests that are negative, which ones match? Where does all of their problems line up? And what's the common denominator? Yo, this is like third grade math. We got it, right? Neuro is no different than third grade math, right? Just find the common problem. All right, we'll make it, we'll get it there. So, spinal cord. We're gonna have high cervical, C1, C5, cervical thoracic, C6, T2, thoracolumbar, T3, L3, and lumbosacral, L4 to S3. Now, 2 years ago, I said I'm a purist. I stood there my first year in teaching and said, we're gonna do it this way. Because I'm a purist, and I still believe that. However, we're just getting closer to the real world, all right? So my academician needs to go back to sleep, and the real world neurologist needs to come out and tell you that you're going to see a lot of people tell you L4S3 as a single unit of localization. Why? Because L4 to S3 segments in the spinal cord are that close together. They literally all live within like an inch of each other. So when I have a disc herniation that ruptures and damages the tip of my cord, yeah, all of those get damaged. The problem is you have to remember that S1, S2, S3 can be affected by itself. And I use the German Shepherd with the lumbosacral disease as a great example. You have this military dog, you are the vet of your, the best vet in your community. The police want to come up and say, hey, he takes care of all of our working dogs and military dogs. She's the one we go to. And then that high agility working dog from the army comes over and his butthole is open up. All right, I'm not saying you should write a news article about every single pet dog you see. But what happens is these high working dogs have a lot of high volumes, high working tension in their rump. A lot of jumping, right? But what happens is you get a disc protrusion. That disc protrusion then pushes up on the cauda equina, and those nerve roots that live back there. In the worst of cases, it pushes up, compresses, and now you get lower motor neuron signs of your anus and your bladder. And so those dogs have to go in and either get an epidural, or more commonly, we have to go in and scoop out and break down that type 2 disc protruding. And so all of that to say, I encourage you to remember that S1, S2, S3 can live on its own, because I think in veterinary education, if you're going to see it as you prep for NAVLE, you're going to merge these. And if they don't, please tell me, because I would love to know that my complaining is finally falling on normal ears. Because some of the older folks who were writing the neuro sections were like, well, and I was like, well, look at this case. Like literally, I've had 4 military dogs that all have it. So just don't worry too much about that. Just be aware that that can happen. So let's talk C1, C5, high cervical. Remember, we're still dealing with a spectrum, right? So I can have a dog that presents with just pain for C1, C5. All of your motor deficits are going to be ipsilateral. So if I have a right-sided lesion, I'm going to have a right-sided proprioceptive deficits. Now, a lot of the time you're going to have bilateral. It's going to affect the entire spinal cord, but I just want you to be aware that you can have it, such as like a vascular stroke, or sorry, like a stroke to the spinal cord, that can absolutely lead to a one-sided lesion. With C1, C5, remember that we do not have lower motor neuron that we care about up there in the neck. Why? Because those lower motor neurons innervate the neck, all right? And really, at the end of the day, clinically, do you think we care about this to this? No, not to see it, right? So clinically, we don't care about the lower motor neurons. The lower motor neurons we care about, the workers, are functioning the 2 big factories called our arms and legs, right? Supervisors live up in the brain. They tell those workers, hey, don't make too much product. We have a small warehouse, and I'm not doing any discounts, right? So when they send that signal down, remember, the default of those lower motor neurons is tone, make product, and they're gonna relax. When I damage the message coming from my upper motor neuron down to the lower motor neuron, my lower motor neurons, when they don't get enough signal, they're gonna do what they know how to do. They're like, the boss ain't telling me, I'm gonna do what I was trained to do, and make tone. So you'll get increased tone when you have dysfunction of the upper motor neuron system. And I can't remember if I kind of come up with this with your class or after your class, but I struggled with upper motor neuron versus lower motor neuron sign. Because when we say upper motor neuron signs, we're actually saying there are signs of dysfunction. And so I encourage you, if you're having trouble mentally understanding the upper motor neuron versus lower motor neuron signs, add the terminology of dysfunction, signs of dysfunction. And I think that can really help our brains conceptualize that that is the part that's broken, not the part that is working and showing its signs. And it really struggled with my brain. So I've switched to saying of dysfunction. So with C1, C5, I have upper motor neuron signs of dysfunction, i.e. that signal's not getting down, so I'm going to get increased tone and increased reflex. Again, these can be normal if I'm getting like 75% of the message, right? These don't have to be increased. But when I get down to that 30, 20% of the signal coming through, that's when I'm going to start to see that increased tone, because I'm not going to have enough inhibition coming from my brain to my limbs. C1, C5, you technically can see ipsilateral waters. Dr. Bowman probably went over with you that it starts here in the thalamus, goes down the neck, comes out the brachial plexus, and goes back up to the eye. It's really, really hard to get a lesion that only affects that part of the neck. It can happen, but really, really hard. So we don't think about it too much. In severe cases, if you have a dog that literally is paralyzed in all 4 legs, chances are they're going to have severe respiratory difficulty, all right? There's all those pathways that control respiration patterns. We get into those like phrenic nerves and things like that, and all these other nerves that supports breathing. And there's actually a little bit of disagreement in vet med as to where the phrenic nerve in different species comes off. Some people learn 3, 4, 5, staying alive, and then other people learn 5, 6, 7, go to heaven, right? Like those are 2 different locations that vet med, for whatever reason, we're just not agreeing on. And it probably has to do with species, not breeds. But it's a discussion for another day. But if you have absentee pain in all limbs, these animals, whether it's C1, C5, or C6, C2, will also start what we call fish breathing. Right? Looks like a fish out of water or gasping for air. But what they're doing, they're using their intercostal muscles for what they can, because their diaphragm isn't functioning well. And so what they're doing is they're using those muscles to create negative pressure to breathe. So that those muscles open up. All right, it looks painful. Again, that's a great sign that you're dealing with really severe. And I will tell you, I've seen that before they get to deep pain negative. A deep pain negative tetraplegic dog is probably a dead dog. Because that is a severe lesion, because there's a ton of room in that neck. But you get that to level, those are the dogs that we have to put on the ventilator, all right? C6T2, right, we're moving just a little bit further down the spine now. Cervical pain still those ipsilateral voluntary motor deficits. And you might be saying, wait a minute, these are where those lower motor neurons live. We have motor deficits with the upper motor neurons. Remember that we have to get the signal and we have to work the machine. The workers do not decide when we change or move the machine. They can only do it with permission from the supervisor. The supervisors don't know how to run the machine. All right, and so you have to have both systems intact to have motor function. And so when there is a breakdown in either of them, it's going to lead to motor deficit. So motor deficits alone do not tell you upper versus lower motor neuron. It doesn't help you subdivide high cervical, low cervical, T3L3, or lumbosacral. It can help you with all four legs or just the back legs. One leg or just right side or left side. It can help with that, but it can't help you with upper versus lower motor neuron because you need both systems to create motor function for voluntary movement. This is where we can see what's called a classic two-engine gait. A classic two-engine gait is when you have signs of lower motor neuron dysfunction, which are the short, choppy strides in the thoracic limbs and long stride limbs in the pelvis. All right. So I'm going to give you two different beats of pace as I walk. I'm going to do the thoracic limbs first and then the pelvic limbs. These sounds are what you're going to be looking for when you're looking for a two-engine gait. All right. So our thoracic limbs are going to be 1, 2, 1, 2, 1, 2, 1, 2, 1, 2. Our pelvic limbs are going to be more 1, 2, 1, 2, 1, 2. So you audibly hear how those are going at two different paces? Well, now think of a dog's legs going at those two different paces. So when you put it together, you're literally getting a dog who's walking really quickly in the back, in the front legs, and slowly in the pelvic legs. And this is a two-engine gait in dogs. And it is very much associated with a C6T2 localization. Some people inappropriately call it a wobbler gait. Wobbler is a specific disease that is common with C6T2. So I absolutely understand why we call it a wobbler gait. However, it is technically inappropriate because wobbler is a disease, not a clinical sign. This is a clinical sign, not a disease. Does that make sense? I'm getting a little pedantic, but you guys know I love doing that. All right. Here, we can also see lameness. The good old neurological lameness. I hate it, I hate it, I hate it. When we have the nerve root involved, either with a peripheral nerve sheath tumor or a lateralized disc herniation, when the nerve root is involved, you can get two things. One, lameness, and it truly looks like a lameness. And a lot of times that presents as a lameness. You're like, I have x-rayed this dog, I have palpated them up and down, I've tapped joints, and I got nothing. And then you send it over to me, I'm like, yeah, because I have a disc herniation, silly. All right. Love it. But you also can get what's called a nerve root sign, all right, or a root signature. What that is the one time where we're actually going to bring the leg up instead of, because usually right in neuro, we drop the leg. It goes flaccid, right? Reduced function. This is the one time we're going to bring it up. And the reason that happens is because this nerve root, where the pain is caused or is being caused, If I have a lateralized disc laying here, if I leave this arm stretched out, now I'm stretching that nerve root over my disc, right? If I bring it up, I'm taking off that pressure because I'm bringing that nerve root up a little bit closer. And so you're taking the pressure off, and you're taking off the stretch from that nerve root. And so that's why that's happening. It is here that the workers of the machines live. Remember, the machines are our limbs. The workers are the lower motor neurons. When we damage the workers, no longer are we going to have the same amount of tone or the reflexes be facilitated, right? Because that's what the workers do. They create tone. They facilitate reflexes. And so if we start to damage them and we take half of them away, we're going to have decreased tone, right? If I get rid of all the workers, now I have absent tone and I have absent reflex. And so that is what happens when we have lower motor neuron signs of dysfunction in the thoracic limbs or the pelvic limbs. With C6T2, you're going to have a decreased or absent tone in the thoracic limbs only. Because with a solitary single lesion, we're only damaging the lower motor neurons at the thoracic limb. Now, lower motor neurons live in the gray matter, right? What's traveling around in the white matter? Axons, right? Axons going to where? The pelvic limb. And so if I have a lesion here, and I'm damaging the lower motor neurons that live here, what's in the between? Those axons, right? And so that's why we can also see clinical signs in the pelvic limb. Now, are my lower motor neurons down here in the pelvic limb involved? No. So what's going to happen to my tone in the pelvic limb? Yeah, normal or increased, right? Depending on the degree of compression. And so with a solitary lesion, you can only have lower motor neuron signs of dysfunction in one pair of legs at a time. If you have signs of lower motor neuron dysfunction in the thoracic limbs and lower motor neuron signs of dysfunction in the pelvic limbs at the same time, you have one of two things happening. One, you have a lower motor neuron condition, thick paralysis, botulism, something like that. All right. Lower motor neuron signs of dysfunction times 4. Think lower motor neuron diseases. Or I have a multifocal / diffuse disease, so a condition that is affecting multiple parts of the spinal cord or the entire spine. Right? Otherwise, with a solitary lesion, such as with a disc herniation, a single disc herniation, you cannot have flaccid, decreased reflexes in the thoracic and the pelvic limbs at the same time. Because these lower motor neurons are going to be functioning if these are damaged. If I have a lesion down here in L4, S3, and those lower motor neurons are damaged, what's happening here with the lower motor neurons in the thoracic limb? They're fine, right? Matter of fact, they're just walking around having great all the time. They don't need those back legs. That's what wheelchairs are for. And so just keep that in mind, that these workers really all belong at the limbs and that they have to have separate entities. But when we're dealing with a C6T2 lesion, we're still dealing with the axons that are coming from the brain down to the pelvic limb, and those also get affected. And that can have an upper motor neuron effect on those pelvic limbs. So just keep that in mind. All right. Ipsilateral horners absolutely can be C6T2. In fact, this is the #1 spinal location where I see ipsilateral horners. T1, T2, T3 specifically. You can also see absent cutaneous trunci reflex. I don't know if y'all remember, the cutaneous trunci reflex, it is the best reflex if it agrees with you. And it is a piece of junk if it doesn't agree. All right? So what does that mean? It means we can't always trust the cutaneous trunci. If it supports us, if it feeds into what we think from other contextual clues, wonderful. But it is actually very difficult to get in cats. And in some dogs, it's just very difficult to get. And that's okay. You're allowed to have individual variability with this. But with C8, T3 lesions, you can actually get, if you have a unilateral lesion, one side affected over the other. Again, with C6, T2, We can get severe respiratory difficulty, especially if we can get to the absent deep pain in all limbs. Again, just a bad area to be. Reflexes of the thoracic limbs. Now, there are a bunch of unreliable reflexes. Now, I know what you're thinking. Why are they unreliable? Something's have to be, right? If I can cut a limb off of an animal and it's still having reflex, does that make sense? No, right? Because the spinal cord is missing from that equation, right? And by definition, a reflex requires a sensory pathway to the spinal cord and back down the motor system, right? And so what happens is that some of these reflexes can also be stimulated by just striking the muscle. And so that is what makes them put into these unreliable. Withdrawal is a highly reliable reflex, and the one I trust the most. I'll still do the others, but withdrawal is who I put my faith in. Remember, when you're performing the withdrawal, you can pinch any toe when you're dealing with a thoracic limb. An intact response is flexion of the limb, both at the elbow and kind of at the shoulder and the carpus, right? You takes all of these to get a full, true withdrawal. And that's why we like withdrawal, because we have to have all of these nerves functioning to get it flexed at all 3 points of the thoracic limb. All right? Withdrawal versus deep pain. If you remember nothing from neurology, it should be that withdrawal and deep pain are separate. Is this ringing a bell? You're like, okay, I remember one thing. If this is the only thing you remember from when I taught you in year one, I'll take my happiness and walk out the door. All right. Remember that withdrawal is different than deep pain. I can cut the spinal cord right here. And I can still have reflexes down here. Why? Because my lower motor neurons, were they alive or dead? Well, they're alive and kicking. Right? And the only thing I need for a reflex, for a withdrawal reflex in the pelvic limb, is a sensory nerve, a spinal cord neuron, and a motor nerve, right? I don't need no freaking brain to make a withdrawal work, because it's a reflex. And so if you pinch that dog's leg and it pulls it away from you, wonderful, you have withdrawal reflex. That tells you nothing about if that dog can feel. What has to happen to tell you that a dog can feel? Yes, all of those. I loved all those. They were coming in real fast, but I loved them all. They have to turn and bite. They have to yell and scream, right? This is the one time that we have to be mean to our patient. And we're doing it out of a place of love and trying to figure out where they are in their prognosis, right? And so that's why we don't start with doing and just screaming, right? But there has to be a cortical response. There has to be that, oh, stop it, type response from the animal. And if there's not, then we don't have deep pain. But simply pulling that limb away, y'all, dogs can be completely paralyzed and they will still move their leg when their leg is touched and the withdrawal reflex is stimulated. That is very difficult for owners to grasp. And it is the number one issue that I have when I have a referring veterinarian send me a case, is that they said it could feel because it moved its leg. All right. That will not happen with future veterinarians in this room. All right. Because I want you to look as brilliant as you are. All right. And so by knowing that, we never have to have that weird, he probably got worse on the drive over. It was 2 minutes. 2 minutes is a long time in neurology. All right. So again, that's kind of the conversation when we have those. We say, well, we don't know what they saw. It progressed, things like that. We often have your backs. Just be aware when you send them for a 90% chance of walking again, and I tell them 50-50. Right? There's a difference. So, and a lot of owners, that's a life and death difference. So just something to keep in mind. All right. Kind of this is everything that we just talked about. T3L3. T3L3 is going to be thoracolumbar. Again, with this, usually your thoracic limbs are going to be normal. All right. You can have ipsilateral or voluntary issues with the limbs bilaterally in the pelvic limb. And again, we're going to have upper motor neuron signs of dysfunction Because in T3L3, the only lower motor neurons live there are for the abs. And y'all, I have lived my entire life without abs, so can dogs, all right? And so we don't really care about abs from a clinical perspective. Matter of fact, on the neurology point, I have no problem going in and actually cutting the nerve root at T3, T13, L1, if it means that I'm taking the dog out of pain, all right? I'm not gonna do that when I have a nerve root that's going to the leg, because that clinical sign is gonna be more dramatic. All right, and so what we did is these upper motor neuron signs of dysfunction, normal to increased tone, normal to increased reflexes in the pelvic limbs, but our thoracic limbs should be normal, with our one exception that we talked about earlier, Schiff-Sherrington. T3L3 is also the time when the cutaneous trunci earns its money, all right? The cutaneous trunci often will be decreased around 2 vertebrae caudal to your lesion. And so the T13 segment, spinal cord segment, is innervating the L2 skin. So the skin that lies over the L2 vertebrae, that information is going in at T13. All right. So what does this mean for us? It means that when I start pinching and I start here at the iliac wings, so and work my way up, when I start pinching, wherever that stops, I can assume that the signal is no longer getting through about 2 segments up, right? Once you get the cutaneous trunci reflex, don't keep going. If it worked at L6, it works at L2, all right? That's just how wires work. So don't keep pinching. There's a couple training videos out there that just irk me like no other, because they're like, do you feel it? How about now? Yeah, how about, I was like, just stop. You felt it the first pinch. That's how the system works. T3L3 really can give you that upper motor neuron bladder. Now, cervical lesions can give you bladder dysfunction, it's just more variable, all right? And when they do give you, it's gonna be upper motor neuron. T3L3 is even bigger to have upper motor neuron, because T3L3, this is where our hypogastric nerve comes out. The hypogastric nerve, throwing you all the way back to Dr. Mansour's micturition lecture, first year, that nerve goes in and is responsible for the sympathetic tone, the storage portion of urine, all right? When we store it, we relax the detrusor muscle. When we store it, right, we want to close the door, exactly, the sphincter. And so when we get rid of that, right, when we damage that sympathetic input, what happens to the tone of that bladder? Right, it's going to contract, it's going to get firm, right? And so when we describe this upper motor neuron bladder, we're talking about a bladder that is hard and firm, but because S1, S2, S3 is also still functional, and that's where the somatic voluntary input comes in, and the involuntary parasympathetic input to the anterior input comes in. Now I have a very tight bladder with a closed door, and very hard to express. So tight bladder, hard to express, is the classic upper motor neuron bladder, or upper motor neuron dysfunction bladder. When a dog loses the ability to walk, they lose the ability to pee. Forgetting the bladder is just as negligent as ignoring the dog. And I truly believe that. So when you're out there and you have a paralyzed dog, you need to address the bladder. And of course, we can be all the way down to where they have decreased sensation and they no longer feel deep pain. We already talked about Schiff-Sherrington earlier today. But again, this is just another place where it is, and a little bit deeper to the why. Those middle managers we talked about that are providing that inhibitory signal up, they're called border cells. The big takeaway is that, one, you have to keep an eye out for Schiff-Sherrington. Don't let it trick you into thinking there's a cervical lesion, like we talked about earlier. Two, it does not affect prognosis. There are textbooks that tell you it affects prognosis. No. The only thing that affects prognosis in a paralyzed patient is whether or not they can or cannot feel their legs. There is no evidence that Schiff-Sherrington dogs are at the same degree, and papers have refuted that. But you will see it, you'll see disagreement in the literature because that's just old school thinking. Just being honest with y'all. So let's get to that final tail part, lumbosacral L4S3. We already talked about how we can break it down. You can even break it down into L4, L5, and L6S1, AKA femoral nerve, sciatic nerve, butt nerve, not pudendal, all right? And this is going to be, again, ipsilateral generalized muscle to the pelvic limbs. Again, if I'm only dealing with S1, S2, S3, my limbs will be normal, right? Walking around with that open bubble, right? We talked about that and what that looks like in those military dogs. When you have an L4S3, if you have a unilateral lesion, this is when you can get monoparesis, all right? What does this look like? We have normal reflexes and normal tone. Yes, ma'am, I'm sorry. Femoral. Yep, femoral, sciatic, pudendal. So normal reflexes and tone and thoracic limbs, right? Because we're here and our lower motor neurons, they're fine up here, right? But now we're dealing with our workers down here at the pelvic. If I have an L4, L5 lesion, I'm gonna have an absent patellar reflex. Withdrawal might be weak, but like my caudal sciatic reflexes will still be intact. If I have a more sciatic lesion, this is where things get a little interesting. You can get what's called a pseudo hyperreflexive. And so we've seen this in cats especially that get like lymphoma of the sciatic nerve. What happens is the sciatic nerves, right, are innervating all these caudal muscles. These caudal muscles are creating tension from the cranial muscles, right? Because we're always in a flexion extension, flexion extension. Well, if I damage the sciatic nerve and I make these muscles weaker, and now I stimulate my patellar reflex. Who's holding these guys back? Nobody, right? And so now it looks like it's hyperreflexive, but really it's just a lack of control. It's not a true hyperreflexive. It's just a lack of balance in the muscles. So if you have a true sciatic lesion, you may get this increased patellar reflex. The big difference, no sciatic withdrawals. No sciatic reflexes. In S1, S2, S3, that's where we're looking at perineal reflex and tone. Here's a nice simplification of all of that for you. Again, same thing, just less words. Yes, ma'am. Yes. Yep, because that's going to be a branch off of the pudendal. Yep. So what else are we going to see? Cutaneous trunci, you may get just a little tiny bit of an elevation like at L5, because I do think once we get this far back, we move from 2 segments closer to 1. So like you might get it up to L5 with an L4 lesion. But again, those last few really don't give off any skin innervation. The bladder. The bladder can be upper motor neuron with L4 to L7, S1-ish. Once I get to S1, S3, now I'm dealing with the lower motor neuron bladder. So if my lower motor neurons are supposed to be my parasympathetic input, and with parasympathetic, I pee, with sympathetic, I store. With parasympathetic, I pee, and that innervates through the pelvic nerve, pee, I'll pee when you pee, right? And so as that comes in, what's supposed to happen to that detrusor muscle when you urinate? It's supposed to contract, right? So if I lose all of that innervation, what's going to happen to my detrusor muscle? Don't relax, right? And so a lower motor neuron bladder, a lower motor neuron dysfunction bladder, is going to be very flaccid. And remember, the sphincters also have all variation in S1, S2, S3. So if they lose innervation, what happens to them? Open, incontinence, you got it. So now we have this large flaccid bladder that's easily expressible. You got it. And so that's a lower motor neuron bladder. This also has the highest likelihood of fecal incontinence because of the anal tone. Now, other parts of the spine can cause fecal incontinence. It tends to be a different kind than this. This tends to be a very diuretic-y looking loose stool, because once the feces hits the rectum, it's out the door, because there ain't no door closed, right? The door's wide open. And that's, I will tell you, out S1, S3 lesions, y'all, it's not a good thing. Had a dog in my residency that got shot there by the owner because he jumped up for the bird. The owner went to shoot the bird, shot the dog in the butt. And so what happened was it damaged S1, S2, S3. 8 weeks that dog stayed in hospital, walked, got him back up and moving, but he never regained control of his anus. So just poop everywhere. That was enough for that owner to say, I can't do this. So after 8 weeks of work, we still stopped. I'll tell you, these are the ones that suck because you have dogs that are walking around doing everything fine except for poop falling out. And we do low volume residual food like DM type diets, still wasn't enough. And an outdoor lifestyle apparently wasn't going to be appropriate. So just throwing that out there. It really sucks. Pelvic limbs, which ones are my least reliable? Gastroc, cranial tibial, again, still good, especially if I'm testing sciatic dysfunction, but I have to interpret them within the clinical picture. Withdrawal and patellar, you can take to the bank. Oh, in the pelvic limb, be aware that you have to separate the medial and lateral because we have the femoral and the pelvic nerve, and they can function separately. So you do need to test medial and lateral in the back. And here's the patellar reflex. We will have a lab where we talk about the neuro exam, all right, and kind of go in through it through my eyes. And so we'll really dive into that stuff there. Cutaneous trunci, again, you're not going to see it with things this far back, maybe just a little bit. On the perineal reflex, we're going to just stimulate either side of the anus. I always say that my patients must all think I'm great because they all wink at me. If only it was the other, all right? And again, anal tone plays a big, big role into that. Two special scenarios I want to mention, spinal shock and cross extensor. Cross extensor is when I have a chronic upper motor neuron lesion. So if I have a lesion, let's say at T3L3, all right, and it's been there for 10 years. If you're down here, and let's say that you are lower motor neuron, and upper motor neuron hasn't talked to you in years, and you're like, I don't think he likes me anymore. And all of a sudden, someone comes by and says, hello, motor neuron, how you doing? How you gonna feel? You're like, hi, I want to talk to you too. Yes, no, I'm having a great time. Life is good. I'm really, really excited that you're here. Can you be my friend? That's what the lower motor neuron does. And so when it's not getting the input from the upper motor neuron, it's going to take whatever it can get. A lot of the time, that is the sensation input externally that we provide. So when you do your withdrawal, all of a sudden this lower motor neuron is like, ooh, someone's paying attention to me. And it gets so excited it kicks out the other side. All right? Because there's crosstalk between the neurons on the right and the left. And the left's like, ooh, that looks fun. Me too. All right? Spinal shock is a phenomenon that occurs in acute trauma. It's pretty uncommon in dogs and cats, but it does absolutely occur. And what it is you get this upper motor neuron lesion, but also reflexes decreased. All right? And usually it improves within 24, 48 hours in our species. However, the big issue is that, unfortunately, the thing you have to determine that about is myelomalacia, spinal cord death, because that also looks like spinal shock. So it's all of a timing thing between spinal shock and myelomalacia. And we will talk about this. We won't get into this case example because we're going to spend tomorrow doing a ton of case examples. And then we already kind of mentioned neuromuscular. Neuromuscular is going to be all of those lower motor neuron signs. When you have lower motor neuron signs in the thoracic limb and the pelvic limb at the same time, think neuromuscular, and we're going to have a whole day on neuromuscular. All right. In the Canvas, right? Canvas, is that what you guys use? Okay. There is a neurolocalization. It's 10 cases that I would love for you to spend some time on tonight if you have a chance. Read through them. That way we can go through them rapidly because I'd like to get through all 10 tomorrow. And they're just practice localization. They're written as I would write them for Natalie. All right. And let's go through and let's rapid fire through those tomorrow. But take a look at it before you get here. At least give it a shot. Could you throw all of these into ChatGPT? Yes. However, the destination is not the goal. It is the journey. It is programming your neurons that this is trying to do. So again, could you get there quickly? Absolutely. It can get you all the answers in 10 seconds. Does that make you a better veterinarian? No. So read through them, think through them, and I will see you guys at 9 a.m. tomorrow. Thank you.